type of sexual dysfunction is disorders of orgasm. During the orgasm phase of the sexual response cycle, a person's sexual pleasure peaks and sexual tension is released as the muscles in the pelvic region contract or draw together rhythmically. The man's semen is ejaculated, and the outer third of the woman's vaginal wall contracts. These functions of this phase of the sexual response cycle are early ejaculation and delayed ejaculation in men, and for women, it is female orgasmic disorder. Premature ejaculation is also called early or rapid ejaculation. A man suffering from premature ejaculation persistently reaches orgasm and ejaculates within 1 minute of beginning sexual activity with a partner and before he wishes to. Clinicians have also suggested that premature ejaculation may be related to anxiety, hurried masturbation experiences during adolescence, such as in fear of being caught by parents, or poor recognition of one's own sexual arousal. For the diagnosis checklist for premature ejaculation, first is for at least 6 months, individual usually ejaculates within 1 minute of beginning sex with a partner and earlier than he wants to. And the second is individual experiences significant distress. For the therapies and treatments, these are the following. The stop-start technique, in which the woman stops all stimulation of the penis when the man first sends an impending ejaculation. And then the serotonin-enhancing antidepressant drugs. It is used to reduce sexual arousal or orgasm. The delayed ejaculation. So it is previously called male orgasmic disorder or inhibited male orgasm. A man with delayed ejaculation persistently is unable to ejaculate or has very delayed ejaculations during sexual activity with a partner. So these are the diagnosis checklists for delayed ejaculation. First, for at least 6 months, individual usually displays a significant delay in frequency or absence of ejaculation during sexual activity with a partner. Second is individual experiences significant distress. For the therapies and treatments, instruct the client to masturbate to orgasm in the presence of his partner or to masturbate just short of orgasm before inserting his penis for intercourse. And if the disorder was caused by physical factors, such as neurologic damage or injury, drugs that increases arousal of the sympathetic nervous system will be given. Another type of disorder of orgasm is the female orgasmic disorder. So women with female orgasmic disorder persistently fail to reach orgasm, have very low intensity orgasm, or have a very delayed orgasm. So women who are more sexually assertive and more comfortable with masturbation tend to have orgasms more regularly. The diagnosis checklists are as follows. For at least 6 months, individual usually displays a significant delay in frequency or absence of orgasm and or is unable to achieve past orgasmic intensity. Second is the individual experiences significant distress. The therapies and treatments, we have the cognitive behavioral techniques, self-exploration, enhancement of the body awareness, and directed masturbation training. And there is also the hormone therapy or the use of sildenafil, which is the Viagra. So the last disorder of the sexual dysfunction is the disorder of sexual pain. So a sexual dysfunction specific to women refers to difficulties with penetration during attempted intercourse or significant pain during intercourse. This disorder is called genitopelvic pain or penetration disorder. For some women, sexual desire is present and arousal and orgasm are easily attained. But the pain during attempted intercourse is also severe that sexual behavior is disrupted. So in other cases, severe anxiety or even panic attacks may occur in anticipation of possible pain during intercourse. So a variety of factors apparently can set the stage of this fear, including anxiety and ignorance about intercourse, exaggerated stories about how painful and bloody the first occasion of intercourse is for women, trauma caused by an unskilled lover who forces his penis into the vagina before the woman is aroused and lubricated, and the trauma of childhood sexual abuse or adult rape. But the most usual presentation of this disorder is referred to as vaginismus, in which the pelvic muscles in the outer third of the vagina undergo involuntary spasm when intercourse is attempted. So women report sensations of ripping, burning, or tearing during attempted intercourse. The diagnosis checklists are as follows. For at least 6 months, individual repeatedly experiences at least one of the following problems: difficulty having vaginal penetration during intercourse, significant vaginal or pelvic pain when trying to have intercourse or penetration, significant fear that vaginal penetration will cause vaginal or pelvic pain, and then the significant tensing of the pelvic muscles during vaginal penetration. Then the second is the individual experiences significant distress from this. Therapies and treatments are as follows: tightening and relaxing vaginal muscles until she gains more voluntary control over them, gradual behavioral exposure treatment to help her overcome her fear of penetration, pain management procedures and sex therapies techniques, medical interventions from topical creams to surgery. So, treatments for sexual dysfunctions. The sex therapy program that was introduced was evolved in a complex approach, which was now includes interventions from their various models, particularly cognitive behavioral, couple, and family system therapies. The goal of sex therapy is to help clients function better sexually and to achieve a higher level of sexual satisfaction and psychological well-being. In recent years, biological interventions, particularly drug therapies, have been added to the treatment arsenal. So what are the general features of sex therapy? Modern sex therapy is short-term and instructive, typically lasting 15 to 20 sessions, and it centers on specific sexual problems rather than broad personality issues. So the following ones are used in almost all cases, regardless of the dysfunction. So first is the assessing and conceptualizing the problem. Second is mutual responsibility. Third, education about sexuality. Fourth, emotion identification. And the fifth, attitude change. Sixth, elimination of performance anxiety and the spectator role. Seventh, increasing sexual and general communication skills. Eighth, changing destructive lifestyles and marital interactions. And then the last is addressing physical and medical factors. For the nursing management, for sexual dysfunction, we should assess the client's sexual history and previous level of satisfaction in sexual relationship, assess the client's level of energy, review medication regimen, observe for the side effects, then provide information regarding sexuality and sexual functioning.